You check the lock. You already checked it twice. You know you checked it, but your hand reaches for it again anyway, as if it has a mind of its own. And somewhere in the back of your awareness, you watch yourself do it and feel completely powerless to stop. That experience has a name, and it is not a quirk. It is not a personality trait. It is not something you can just push through by trying harder. It is OCD, and it is one of the most misunderstood conditions in all of psychology. Most people think OCD is about being neat, a preference for order, a love of symmetry, maybe a little perfectionism. The truth is far more complicated, far more painful, and far more diverse than that. OCD is not one thing. It is a family of subtypes, each one organized around a different fear, a different obsession, a different compulsion, and each one can completely take over the life of the person experiencing it. According to the World Health Organization, OCD affects roughly 2.3% of the global population at some point in their lives. That is around 200 million people. Yet the vast majority of them go undiagnosed or misdiagnosed for years, often because their OCD does not look the way people expect it to. So let's walk through what OCD actually is, and then let's walk through every major type. At its core, OCD is a cycle. An obsession arrives. An obsession is not simply a worry or a preference. It is an intrusive, unwanted thought, image, urge, or doubt that your brain treats as an emergency signal even when there is no emergency. The obsession creates intense anxiety. To relieve that anxiety, your nervous system searches for something to do. It finds a compulsion. A compulsion is a behavior, mental or physical, performed to neutralize the anxiety. You do the compulsion. The anxiety drops, but only temporarily, because the compulsion teaches your brain that the only way to feel safe is to do it again. And so the cycle tightens. Paul Salkovskis, a clinical psychologist at the University of Oxford, spent decades studying why this cycle is so difficult to break. His research showed that what keeps OCD alive is not the obsession itself. It is the meaning the person attaches to it. When your brain generates an intrusive thought and you interpret it as a signal that you are dangerous or contaminated or responsible for preventing harm, you have handed that thought enormous power over you. The compulsion feels like a logical response, but it is actually the mechanism that locks the cycle in place. Now, let's go through the types. Contamination OCD is what most people picture when they think of the condition. Your brain generates a thought. You have been contaminated. Maybe you touched a door handle. Maybe you walked through a hospital. Maybe you sat on public transport. The thought arrives, and your nervous system treats it like a genuine threat. The anxiety is immediate and physical. Your heart rate climbs. Your skin feels wrong. And the only thing that brings temporary relief is washing, cleaning, avoiding. People with contamination OCD often wash their hands until they bleed, avoid entire sections of their daily life, and spend hours each day performing cleaning rituals. The contamination is not always about germs. It can be about chemicals, toxins, bodily fluids, or the idea of moral or emotional contamination from contact with a specific person or place. Checking OCD is organized around doubt. The core fear is that something terrible will happen because you failed to prevent it. Did you lock the door? Did you turn off the stove? Did you unplug the iron? Your brain generates the doubt and then refuses to accept the answer you give it. You check. The anxiety drops for a moment. Then the doubt returns. So you check again and again. People with checking OCD sometimes spend hours at the door before they can leave for work. Some drive back home multiple times to verify. Some cannot leave at all. Harm OCD is one of the most distressing and least understood subtypes. The intrusive thoughts here are violent. You might be holding a knife, and suddenly your brain generates an image of harming someone you love. You might be driving, and your brain flashes a thought about swerving into oncoming traffic. You might be near a child and a deeply disturbing thought arrives without warning. These thoughts feel horrifying precisely because they conflict with everything you value. Here is the critical point. People with harm OCD have no desire to act on these thoughts. In fact, the fear of the thought, the revulsion toward it, is exactly what fuels its power. They are not dangerous people. They are people whose brains have latched onto the thing they fear most. Paul Salkovskis' research is directly relevant here. He demonstrated that virtually all people experience intrusive thoughts. A 1978 study by Stanley Rachman and Padmal De Silva found that the content of obsessional thoughts reported by OCD patients was nearly identical to the unwanted intrusive thoughts reported by people without OCD. The difference was not the thought. It was what the brain did with it. Responsibility, OCD, sometimes called scrupulosity in its moral form, is built around an inflated sense of responsibility. Your brain tells you that if something bad happens and you could have prevented it, it is your fault. You feel compelled to warn people about every possible danger. You replay past events looking for evidence that you caused harm. You confess repeatedly to people around you seeking reassurance. The reassurance helps for a few minutes. Then the doubt returns. In its religious form, scrupulosity generates obsessions about sin, blasphemy, and moral impurity, driving compulsions like excessive prayer, confession, and avoidance of anything that might trigger a religious thought. Symmetry and Ordering OCD is not about aesthetic preference. The person is not simply particular about how things are arranged. The underlying driver is a feeling that something terrible will happen if things are not exactly right, or a feeling often described as not just right, a kind of internal wrongness that demands relief through arrangement, counting, or repeating. Jeff Szymanski, a psychologist who has worked extensively with OCD, describes this as a tolerance for uncertainty problem. The brain generates unbearable tension, and the compulsion, whether it is aligning objects, counting silently, or repeating movements a specific number of times, temporarily resolves it. Pure OOCD is a term used by many patients to describe a form of OCD in which the compulsions are entirely mental rather than behavioral. There is no visible checking or washing. Instead, the person is performing exhausting internal rituals, analyzing thoughts, seeking internal certainty, reviewing memories, or mentally neutralizing a disturbing image by replacing it with a safe one. The O stands for obsessional, but the label is slightly misleading because there are still compulsions. They are just invisible. Intrusive thoughts in this subtype often focus on sexuality, identity, relationships, or existential doubt. Sexual orientation, OCD, sometimes called HOCD,